Hello and welcome to Lecture 24. We are transitioning from drugs of abuse to drugs that are used to treat specific conditions. And in this particular case, we'll be sort of bridging that with drugs that are both used to treat pain and also have a high potential for abuse. So we're going to start with an introduction to narcotic pain relievers and talk about morphine. And morphine is sort of the standard by which all painkillers are sort of compared. So first I want to talk about why pain relief is such an important issue and why we need to have adequate pain relief, but also have drugs available that are less addictive than the class of drugs that we have available now. So the total cost of pain in 2012 are estimated from $560 to $635 billion. So you can imagine that would be far greater now. The additional health costs due to pain ranged from $261 to $300 billion. Lost productivity, another $300 billion. Annual cost of pain was greater than the annual cost of heart disease, cancer, and diabetes. And this all comes from the economic cost of pain in the United States. So this is a really important thing to understand. One thing we have to realize about untreated health conditions is not just the cost on the individual, but it's a cost to society as well due to lost productivity, etc. So anytime we have this kind of issue, we have to consider it our moral duty, first of all, because we want to take care of one another, in my opinion, but also understand that it's not just the individual, but all of us who also suffer. So over this series of lectures, we're going to talk about all of these issues, talk about pain perception, the history of opioids, some terminology, talk about opioid receptors, classification of opioid analgesics and morphine, and that will be this lecture. In the next lecture, we'll talk about other pure opioid agonists, partial agonists, and then get into prescription opioid abuse. And then in the third lecture in this pain relief series, we'll talk about other pain relief options like nonsteroidal anti-inflammatory drugs, aspirin, and CBD and medical marijuana. So, first question is, what is pain? It is both a sensory event and an emotional cognitive experience. That is, something in the peripheral nervous system triggers a pain signal, and we interpret that signal on an emotional and cognitive basis. And it's important to understand because that emotional and cognitive experience is an important part of understanding differences in pain perception and how we can use some things like distraction to help aid people who are potentially in some pain, not severe pain, but certainly some pain, can be helped by a good positive emotional distraction. Certainly acute pain is desirable. It serves to warn us of damage. Chronic pain, however, serves no purpose other than to be certainly debilitating to people that suffer from it. But that acute pain is something we need to know about. In fact, there are people who are born who can't experience pain, and they generally don't live very long because they don't know when they've stepped on a piece of glass and are bleeding. They don't know if their appendix has ruptured. They don't know if they've had a heart attack. And so pain is a really useful signal. So a couple things to realize is that pain relief can occur at the site of injury. So we can use nonsteroidal anti-inflammatory drugs or even ice to reduce inflammation. A big part of pain is inflammation, which is why CBD oils oftentimes at the site of inflammation seems to be very effective. But we'll get into that here in a little bit. Or we can also get pain relief via central mechanisms affecting primarily opioids, endorphins, and the pain-inhibiting pathways. So we can block pain in the brain, or we can block it at the site of injury. So the first thing to understand is the idea of nociception, and this is basically nociceptive pain. So when the body's damaged, we get these nociceptors or pain-sensing neurons that can respond to mechanical, thermal, or chemical injuries. So when you cut yourself, burn yourself, or then cut yourself and squeeze a lime or a lemon. Let's say you've got a paper cut on your fingertips and then you have to squeeze a lime or a lemon. That's going to be a chemical injury on top of the mechanical injury. In the brain, the mechanisms associated with pain are really complex. So it's dependent on both the peripheral nervous system and its modulation at the multiple levels of the nervous system. So we can actually block pain from the top down. That is, you can actually mentally block pain. There's a couple of instances in this with athletes in particular. Most of the time it's because they already have a high level of endorphins due to the athletic event. But you can block pain temporarily, but not for long. And certainly it's not advisable. We've all seen gymnasts who have injuries who go on to finish their routines and then are really disabled afterwards. So keep that in mind. So neuropathic pain, or what we call peripheral neuropathy, is a serious problem. This is generally caused by some sort of dysfunction in the nervous system. This could be a lesion, or it could be a change in the way in which pain receptors are responding. So this is characterized by an increased sensitivity, what we call hyperalgesia, to pain-producing or even innocuous non-painful stimuli. And individuals who have this kind of neuropathic pain, even clothes on their skin or a light sheet on their skin, can cause extreme pain because it's activating those pain receptors from an innocuous or non-painful stimulus. And this is something we're really trying to get a hold on because it really is severely disabling to people who have this kind of peripheral neuropathy. So here's a little bit about pain signaling. So you have signals in your or sensory receptors in your skin that then goes up to the spinal cord. You actually have an interneuron that will connect to a motor neuron. So in the event that, say, you have put your hand on something hot, the reflex to take it away from that heat will occur before anything even reaches the brain. So then we get up to the brainstem, and then the para-aqueductal gray is a big part of pain relief. The amygdala is the emotional part of the response to pain, and then the cerebral cortex and the thalamus are also involved in the interpretation of pain. And so all of these get involved in our pain signals. So analgesic drugs come in a variety of formats. The primary ones we're talking about in these first two lectures are all opioids or narcotic analgesics. Non-opioid analgesics tend to include things like anti-inflammatory drugs, or what we call NSAIDs for non-steroidal anti-inflammatory drugs. There are also some analgesic adjuvants, things like antidepressants. Some anticonvulsant medications seem to have some benefit for particularly peripheral neuropathy. And then there are some things that are NMDA antagonists like dextromethorphan, which we talked about previously when we talked about psychedelic drugs. So these have potential to help relieve pain as well. So oftentimes depression patients have sort of light chronic pain, and antidepressants can help treat that kind of pain. And then tetrahydrocannabinol is certainly one that has the potential for treating pain. We know that the drug Sativex, that is approved in Canada, is particularly effective for treating the chronic pain associated with multiple sclerosis. So these are all analgesic drugs. So these modulate pain in a variety of ways. One, they reduce the peripheral inflammatory response to injury. And this is an important part of treating, particularly like a sports injury, because the inflammation is really what's causing the pain. And so oftentimes corticosteroids are also injected or given as a response to reduce that inflammation. Whenever you're taking something like a prednisone drug or methylprednisone, that's being taken to reduce that inflammation. You can also block the glutamatergic NMDA receptors in the spinal cord. That's what dextromethorphan and ketamine are designed to do. The other thing we try to do is reduce repetitive activity in injured neurons. So that's what those anticonvulsant neuromodulators are often used for. So particularly the drug gabapentin seems to be particularly effective for that. Also potentially modulating the spinal cord through activation of inhibitory endorphin or GABA neurons. This is done through opioids or neuromodulators. The descending inhibitory neurons are primarily influenced by opioids and antidepressants, and then the central processing of pain is primarily handled by opioids. So there are a variety of different ways in which we can try to manage pain and modulate pain by affecting each of these different parts of the nervous system. That gets us to opioids. Certainly, these are some of the oldest classes of drug known. There's over 7,000 years of use of these because it is opium poppy is essentially what these are derived from, which is why they're called opioids. In the Middle Ages, Paracelsus or Paracelsus combined opium, wine, and spices into a drink called laudanum, something to be praised. So that was used for treating pain. It was popular in the U.S. As an ingredient in many over-the-counter medicines until it became illegal in 1914. So opium was certainly used quite a bit. We certainly know about opium dens from a variety of literature and historical accounts. It was replaced by heroin use from Turkey, then Asia, particularly during the Vietnam period. Now it comes from Russia, Mexico, Colombia, and Afghanistan is another big opium producer as well. Now remember, some opium production is needed for creating prescription opioids, but certainly we don't need the influx of heroin that we have had of late. So I do want to stop and talk about the laudanum. This has kind of made a slight comeback in some circles. Some people call it purple drank or sizzurp. This is essentially codeine and promethazine cough syrup, which in some locations you can get without a prescription. So be mindful of that because it's not something you really want to mess with because this is particularly dangerous. And it's mixed with usually Sprite, Jolly Ranchers, and other stuff. This can be potentially very dangerous because the amount consumed can lead to an overdose relatively quickly. And we've all heard news stories of people who have been hospitalized with overdoses of this particular drug. A little terminology about these drugs. Opium, this is the extract of the opium poppy. This contains both morphine and codeine as natural products. When we talk about an opioid, it's any agonist with morphine-like activity. So there are a lot of synthetic opioids we'll talk about. An opiate is a drug, morphine, codeine, or heroin that is derived from the opium poppy. A narcotic is really any sleep-inducing drug, but today we refer to narcotics as illegal drugs. So that's kind of a misnomer in some cases. Endorphins are any endogenous compounds formed in us or any other living animal that exhibits pharmacological properties of morphine. So our natural endorphins are natural pain relievers, and these are things that are released oftentimes with things like exercise and stress, which is why people get a runner's high, is because of the release of those endorphins. The opioid receptors are contained in a variety of places. The protein receptors, which morphine acts upon. There are 3 types of these, the mu, kappa, and delta receptors, and we're going to talk a great deal about these and the various types of receptors that are affected by different drugs. So these are important terms for you to understand as we go forward because we'll be using them quite a bit. So the mu receptor is responsible for analgesia, respiration depression, and this is particularly important for us to think about because this is what overdose deaths are caused by, is the reduction in respiration. People stop breathing. It's also associated with euphoria, sedation, sense of tranquility, reduced apprehension and concern, cough suppression, which is why codeine is often contained in cough medication, and also reduced GI motility. And in fact, that's one of the biggest side effects of opioids is constipation. In fact, my father had a liver transplant and then also had lung cancer. And so he was taking quite a few painkillers, and because of his reduced GI motility, his blood pH would get really far off, and he would have sudden, very sort of dense amnesia and dementia that would resolve as quickly as they got his blood pH back, but it's certainly something to keep in mind. The Kappa Receptor, this is spinal analgesia, a little dysphoria, some psychotomimetic effects, but minimal respiratory depression. So in a spinal block, that's where the spinal block drugs are going to go is toward those kappa receptors. Some drugs, such as sulfonylurea A, are pure kappa agonist psychedelic drugs. The delta receptors have little analgesia, but possible antidepressant and anxiolytic properties, so possibly relieving anxiety and depression. But primarily we're going to talk about the mu receptor because this is where all of the action is for most of the drugs we're going to talk about. So opioids, in addition to relieving pain, cause respiratory depression, and this is what kills people from an overdose, that and the sedation. It decreases the respiratory center's sensitivity to higher levels of carbon dioxide in the blood. And so normally when your carbon dioxide builds up in the blood, you will start breathing very rapidly. And so because those sensors are no longer responding, you simply just breathe as normally, and then that carbon dioxide builds up, and because of that, you will stop breathing. It also depresses the cough reflex, so that's its antitussive action. Reduces nausea and vomiting, can cause nausea and vomiting, causes constipation as well as urine retention, pupil constriction, and euphoria by disinhibiting the inhibitory effect of GABA on dopamine neurons. We think is primarily how this is effective in the reward pathway. So this is unlike some of the other drugs we've talked about that influence dopamine directly. This is much like alcohol in its effect on inhibiting GABA and then causing an increase in the release of dopamine neurons in the reward pathway. So a couple things to think about in terms of the overall opioid action. The limbic system controls our emotions, and opiates act to produce feelings of pleasure, relaxation, contentment. And so this is one of the powerful lures of these drugs, is they do act as a sort of chemical relaxant, and people feel relaxed and happy or pleasure while they're on these drugs. And so certainly stress, anxiety, and trauma are oftentimes precursors to addiction to these drugs. So the brainstem controls autonomic nervous system responding, breathing, coughing, and opiates have effects on those as well. Then finally, by acting on the spinal cord, opiates block those pain messages and allow people to bear even serious injuries. And so these drugs have a lot of certainly important use. So if you have surgery or if you've broken a bone, you'll need to take these drugs. I had surgery on my foot just last December, and they tried doing a nerve block in hopes that I wouldn't need pain relievers. And I woke up in the recovery room with the nerve block not working, and they had cut all the way through one of my toe bones and screwed it back together. And I can assure you that I was in a great deal of pain, and so they acted very quickly and got that pain under control. So this is an important part of understanding how we control pain in things like surgical settings. How we classify opioid analgesics: first of all, an agonist is any substance that has an affinity for the mu receptor. Partial agonists are those that have an affinity, but only partial efficacy, that is, they have limited action. And that's really important because when we talk about which drugs have a big affinity and efficacy, that's important. Mixed agonist antagonists, they will bind to opioid receptors and cause analgesia in a non-opioid dependent person, but may precipitate withdrawal in an opioid dependent person. And then we will talk about pure antagonists. They have an affinity for the mu receptor, but is devoid of morphine action. And these are drugs that are used to reverse overdose. So Narcan or naloxone and naltrexone are the drugs that we'll talk about that are used to reverse an overdose. Pure agonists include morphine, heroin, Dilaudid, Demerol, fentanyl, oxycodone, and codeine. Partial agonists are buprenorphine. This is a component of Suboxone, and in the next lecture we'll talk quite a bit about how it's used to treat opioid addiction. Mixed agonist antagonists include a variety of drugs listed here: Talwin, Stadol, Nubane, and Dalgan. And then the pure antagonists are things like Narcan, Trexan, Vivitrol, Revex, and Rovia. Narcan is the primary go-to drug in this case, which is naloxone. So this is a nice summary of all of these drugs. If you need more information, you can pause here. Those of you in my course can, of course, access the PowerPoint slides yourselves. These all have a variety of different effects, but the sort of natural Opioids include morphine and codeine. Fentanyl is entirely synthetic. Oxycodone, hydrocodone, and hydromorphone and oxymorphone are all semi-synthetic, as is heroin. Heroin is not used as an analgesic. It is class 1 narcotics we talked about previously. We're going to start talking about morphine and codeine. These are the two analgesics found in the opium poppy. Codeine is, of course, much less potent, but they're used to manufacture morphine, codeine, and heroin. And heroin is the most potent of the opiates, which is why it is a class 1 narcotic. Morphine is certainly the most effective drug for treating pain. It's certainly very potent. Fentanyl is actually more potent. And we'll talk more about that here in a bit. Fentanyl has some dangers, but it certainly is very effective in treating pain. But we're going to start by talking about morphine. Morphine is generally administered. Absorption from the GI tract is slow and incomplete, so generally this is almost always injected. Anybody who's had sort of major surgery, oftentimes if you're in the hospital, you've had a major injury, they'll hook you up to a morphine drip and you can push a button to get pain relief. It doesn't always give you morphine, but a little placebo goes a long way in those cases as well. It can be injected directly to the spinal cord to block pain. That's usually what we do with a spinal block. It does cross the blood-brain barrier slowly. Heroin and fentanyl cross much faster, which is why these drugs have a much greater abuse potential. Only 20% of injected morphine reaches the central nervous system. Metabolized into an active metabolite, which is a much more potent analgesic, and they both have about 3 to 5 hour half-lives. So this drug has to be administered fairly regularly. And most of that analgesic action comes from the active metabolite. And we'll talk about oxycodone and hydrocodone and their metabolic properties in the next lecture. But those are also very important. In terms of the pharmacological effects of morphine, of course, analgesia has some euphoria, which is that reward system we've talked about. Oftentimes creates a drive state in which need for the drug can outweigh other drives, so it's very important to watch for that. It certainly is sedating and relieves anxiety, depresses respiration, expressions of cough, pupillary constriction, tendency for serious constipation. There are also some endocrine effects, including decreased libido and menstrual irregularities in women. So a variety of pharmacological effects. This is, one of the pretty dangerous drugs if not used under appropriate supervision. So that's where we get to is tolerance and dependence. Certainly tolerance to all opioids develop. There's cross-tolerance from one opioid to another. We certainly know physical dependence can develop. This is, again, very much like heroin. Can be incredibly addictive. Certainly people who take a lot of morphine will have to probably step down from it because they'll go into withdrawal. My grandmother died of ovarian cancer, and she was a former nurse, and in her day, morphine was basically all they had. But she had seen so many people addicted to it that she didn't want to take her morphine. Well, she was dying, and we were like, well, what do you care if you're addicted to morphine? Bottoms up. And so she eventually got to where she would take them. So that withdrawal includes restlessness, drug craving, sweating, really extreme anxiety, real irritable, depression, fever, chills, retching, cramps, insomnia, explosive diarrhea, intense aches and pains. I mean, this is a really, really serious physical withdrawal. And this is one of the problems with heroin as well, particularly when people are suddenly treated with Narcan, is it throws them right into withdrawal. I mean, obviously save their life first, but this withdrawal symptoms can be very severe and should be treated. So these generally aren't life-threatening, but can seem unbearable. So this is one of the reasons why these drugs have such an addictive nature to them, is because it's oftentimes more avoiding withdrawal than it is the drug itself that people are addicted to. All right, well, that's it for our this first lecture on opioids and opiates. In the next lecture, we'll get into the rest of the drugs in these classes and talk a little bit about dependence and treatment options.